Very good afternoon to all. I'll be talking regarding collagen cross-linking. So, this is the study by Theo Seeler and Sproul, which was published in 1997. It was a landmark paper which introduced collagen cross-linking as a treatment for keratoconus. Since then, the treatment of keratoconus has never been the same, but still it is the gold standard treatment to arrest the progression of corneal ectatic conditions. It uses photoriboflavin and a photosensitizer that is to peak the absorption at 370 nanometer. It actually uses riboflavin and UVA to produce photopolymerization using free radicals, which will increase the intrafibrillar and interfibrillar covalent bonds. The primary purpose of cross-linking is to halt the progression of the disease. Likewise, the best candidate is an individual with a progressive disease of cornea. And the most common indications are keratoconus, then pellucid marginal degeneration, Tedious marginal degeneration, post-refractive surgery, ectasia. There is no definitive criteria for progression, but parameters to consider are change in refraction, uncorrected visual acuity, backscatter corrected visual acuity, and corneal shape on topography and tomography. Contraindications are for the standard protocol is less than 400 microns, prior herpetic infection, any concurrent infection, corneal scarring or pacification, history of poor wound healing, severe ocular surface disease, autoimmune disorders, pregnancy, breastfeeding, and very young patients. So, the conventional CXL is the distance protocol, which is done under topical anesthesia, removal of central 7 to 9 millimeter of epithelium with application of 0.1% riboflavin, phosphate, and 20% dextran solution every 5 minutes for 30 minutes, followed by irradiation of UVA for 30 minutes. And topical antibiotic with bandage contact lens. So the other protocols after the distant protocol came to decrease the amount of time while keeping the same effect, that is accelerated cross-linking, transepithelial, pulse cross-linking, customized cross-linking, adapted fluence cross-linking, and antiphoresis mediated cross-linking. Accelerated cross-linking based on the photochemical effect of irradiation is proportional to total energy delivered, irrespective of the intensity and total time of delivery. Accelerated cross-linking has found to be safe in stem studies, but it's practically found not to be as effective as the conventional normal CXL. So these are the different riboflavin concentrations and fluences used for accelerated cross-linking. And different studies have shown that 10-minute protocol is better than 5-minute protocol, but the rest of the parameters not much of significant difference. Both accelerated and standard are effective in stabilizing keratoconus, but better visual acuity and K values are with standard protocol. The other strategies are pulse cross-linking, which is based on the fact that the oxygen depletes 20 seconds into the initiation of treatment. So pulse delivery of UVA allows some amount of reoxygenation, thus better cross-linking. And customized cross-linking to concentric, which gives better surface normalization and not much significant increase in haze. And adapted fluence cross-linking, in which the energy is changed to give the customization. So the transepithelial cross-linking is basically done for thinner corneas, but the presence of epithelium may hinder the absorption of riboflavin. But it will the permeability of the riboflavin need to be increased by either chemical enhancers or superficial epithelial scraping, mechanical epithelial disruptors, or stromal channels or flaps. So these are the basic two techniques: the epithelium off and epithelial transepithelial. The epithelial off is the gold standard, but has more postoperative pain and discomfort, higher rate of postoperative possibility of infections, stromal haze is more, and decreased vision in initial postoperative weeks, but better efficacy in halting ectasia progression. So the efficacy of transepithelial CXL as a treatment is studied in different studies, in which the oxygen enhanced transepithelial CXL being the most effective and comparable to standard epithelium of CXL. So this is the newer edition, which is supposed to come in 2026. This is EpiSmart or Epi-on cross-linking, resulted in the mean improvement of uncorrected and best corrected visual acuity with an excellent safety and efficacy profile in subjects with keratoconus with few significant side effects. This is an incision-free topical drug therapy for keratoconus. This represents a novel and groundbreaking therapy for patients of keratoconus. So iontophoresis assisted CXL is like a electrode is used to drive the riboflavin into the cornea by giving an electrical gradient. It's done for 5 minutes, and then the UVA is applied. So the effectivity is like the EP of CXL is the most effective, then iontophoretic, then the transepithelial cross-linking. So CXL in thin corneas, the modifications are the hypoosmolar riboflavin is used to swell the cornea, and then it more than 400 microns, and then UVA is applied. And CXL with custom epithelial debridement, that the central part of the cornea is debrided and the peripheral part is kept, so that the more lesser endothelial toxicity. Contact lens assisted is the contact lens is soaked with riboflavin, and it's without a UVA barrier, so it will swell the cornea into a thicker cornea, and then you can use the UVA in thin corneas. Smile assisted uses a lenticule over the scraped cornea, and then CXL is done. This is also for thin corneas. Adapted fluence already I have told. So these are the modalities which are being used. So with hyperosmolar riboflavin, which is found to be free of endothelial toxicity in corneas less than 330 microns, that may not be effective. And transepithelial, the shallow demarcation line less effective, and contact lens all have their own limitations, the gold standard still being the distance protocol. So it can be combined with vision correction, with LASIK, with phakic IOLs, and photorefractive keratectomy and intracorneal ring segments to give visual improvement also along with the collagen cross-linking. These are the different vision enhancing procedures that is possible with it can be combined with CXL. can be done as two separate sessions, but simultaneous approach is found to be more effective. So to conclude, collagen cross-linking is an FDA approved in 2016 single most effective way to halt the progression of keratoconus. The risk of CXL are substantially fewer than the risk of transplantation. Studies of different techniques including epion treatment, changes in UV light parameters and riboflavin composition continue to proceed with the hope of improving the safety and efficacy of the procedure. Thank you.